Okay, hello everyone, and thank you for joining today's Call for Quality Measures webinar. During today's webinar, the Centers for Medicare and Medicaid Services will provide an overview of the 2021 Call for Quality Measures process, including the timeline and measure evaluation process to assist with measure development for future MIPS performance periods. And after the webinar, CMS will take as many questions as time allows. So now I will turn it over to Dr. Daniel Green, a medical officer within the Quality Measurement and Value-Based Incentives Group at CMS, to begin.
Thank you, Lauren. Welcome, everybody. Thank you all for joining today's presentation. We're very happy that you were able to take time out of your busy schedules to listen to and provide some input as to what we're looking for in measures for the MIPS program. Next slide, please. And the next slide, please. Okay, so this is our typical CMS talk disclaimer. Next slide, please. Just want to do a quick run through of what the agenda holds for us today. So obviously this brief introduction, we'll have an overview of the call for measures. We'll go over some of the requirements, measure evaluation considerations, our future state, resources, and question and answer. So hopefully at the end of this presentation and question and answer session, you guys will be able to have a better understanding of what CMS is looking for measures on our measures under consideration list as we move forward with the MIPS program. So at this point, I'm going to break for just 1 second. I have the pleasure of introducing Dr. Michelle Schreiber. Dr. Schreiber is the group director for the Division of Quality Measures and Value-Based Incentive Program group. She's also the deputy director in the Clinical Standards and Quality Group, which is the parent organization, if you will, of QuimVig. Michelle is a practicing internist from Michigan, where she led the quality programs, if you will, for the Henry Ford Hospital. She's also a fellow dog lover. So Michelle, let me turn it over to you. Thank you.
Thank you, Dr. Green. I think that last one may have been the most important one. Both Dr. Green and I share a passion for our dogs. Welcome everybody to today's session. We're very glad that you were able to attend. I'd like to just take a moment to thank all of the CMS staff who are on the call, who really worked very hard on these programs and on these measures, and to our vendor, Ketchum, for having organized today. But most importantly, thank you to each and every one of you who are on the call today and who may even represent other organizations. In particular, to any providers who are on the call. This last year obviously has been one of tremendous challenge. We know that practices have been significantly affected and that people have been really working incredibly hard to manage during the COVID pandemic. And on behalf of CMS, we say thank you, a sincere and hearty thanks really to each and every one of you. You are the true healthcare heroes, and we deeply appreciate it. I wanted to spend a few minutes today to really talk about where CMS views measures going forward in the future and what some of our plans are for even using measures, to give you a better idea of what may be coming forward as higher priority areas as you start developing measures and bringing measures forward. There's probably nothing more frustrating than putting a lot of work into developing a measure only to find out, no, not going in that direction after 2 years. So hopefully by setting the stage here, it will become more clear what CMS is hoping to achieve, at least over the next few years, recognizing that this may obviously continue to evolve. If I could have the next slide, please. And actually, we can skip forward. So over the last year, CMS has been putting together its specific quality action plan regarding quality measurement. And our vision, which I think everybody shares this vision, is to use impactful quality measures to improve health outcomes and deliver value by empowering our patients to make informed care decisions, while at the same time reducing burden to clinicians and making measurement meaningful to clinicians as well. Next slide. Many of you are familiar actually with the Meaningful Measures framework that we started in 2017, and we've had significant success with that. So that had outlined a series of 6 domains and 17 different focus areas and created priorities for us as to where we tried to focus our measures. We have further refined meaningful measures, and we'll show you that in just a moment, but use that in the context of the overall strategies and goals of the CMS Quality Measures Action Plan. The first of those goals is to use the meaningful measures framework to streamline and really align quality measurement. And by align, I mean align across CMS. So for example, CMS fee-for-service, Medicaid, CMMI, to align across our federal partners such as VA and DOD, and we meet with them frequently, as well as to align in the healthcare space writ large. Many of you are familiar with the CQMC, the Core Quality Measures Collaborative, which is AHIP, America's Health Insurance Plans, CMS and NQF trying to determine a core set of measures that will be used by all payers. So we recognize that there's a lot of work to do in alignment and in streamlining and continuing to identify those areas of highest impact while we continue to make measures better. The second goal of the action plan is, once we have measures, to leverage them to drive improvement. And CMS's levers include public reporting and our value-based payment programs. Many of our programs are pay for reporting, but many of them, as you're very familiar, include incentives and/or penalties. Measures are obviously the essential building blocks of these programs. We continue to be modernizing our programs, in particular the MIPS program. As you know, we're making that transition to MIPS value-based pathways so that we will have smaller sets of cohesive measures that relate to each other, from quality to promoting interoperability to improvement activities to cost, as well as a foundational level, all geared to improving a certain aspect of care, such as improving prevention or improving joint replacement surgery. So we're really looking forward to that and appreciate all of you who have been part of those conversations as we've been developing those programs. We've also been working on our other value-based programs, for example, improving and having released a new version of the hospital stars rating. Many of you may be familiar with the fact that we're expanding the SNF value-based purchasing program. That legislation just passed as part of the Consolidated Appropriations Act. And so we continue to move on all of our value-based programs to make them more meaningful and hopefully modernize them. We want to improve the efficiency of our measures by transitioning all of our measures to digital measures. So CMS set out the goal at last year's CMS Quality Conference to transition to all digital measures in 2030. And our former administrator, Seema Verma, really wanted to accelerate that timeline. And so we're targeting actually 2025, recognizing full well that that's a very aggressive timeline. Now we have a broad view of what a digital measure is, and it is not only an electronic clinical quality measure, which is derived from the electronic medical record, but it could be claims-based measures, and it could even evolve to be measures that take data from a downloadable patient device. The advantage of using digital measures is that we feel with interoperability, we can have more seamless access to information. We can provide rapid cycle feedbacks, and we can leverage advanced data analytics to view measures in a way that we never could before. And so a key strategy is for us to transition to digital measures. And I will go out on a limb a little bit by saying that, at least for use in our programs, we will likely be insisting on digital measures in the future. As a matter of fact, this year's MUC list that went to the MAP was 80% digital measures. Measures are also important to empower consumers to make the best healthcare choices through patient-directed quality measures, through public transparency, and certainly by increasing patient-reported outcomes measures. We know that PROMs have been sort of clunky to use, and we're looking for recommendations and programs where we can work out how to best use PROMs. But CMS has made the commitment to increase patient-reported outcomes by 50% over the next several years. We've also made the commitment to improving our public transparency. You've seen the latest version of the Compare site that was updated several months ago to make it easier for consumers to really understand information and be able to make best healthcare choices. We also highly prioritize those measures that we would consider patient-centered or patient-directed, such as shared decision-making, for example. And finally, we believe that measures can shine a spotlight on disparities, and we would like to leverage our quality measures to promote equity and close those gaps of care. So we'll be looking for measures around social determinants of health or how we can actually drive equity and decrease disparities. If I could have the next slide. This is a schematic diagram of our New Meaningful Measures 2.0. I guess I'm looking at it and it's on my right side, but the house diagram, that our goal is really building towards value-based care with the patient and caregivers and family at the true north and top of this diagram. We have 8 specific domains of care. We took away the 17 different focus areas to really create domains of care that we think are the highest priority. Person-centered care, which I spoke of recently, equity, safety, and just so you know, we had called it patient safety, but we've called it safety to have a broader focus on the healthcare ecosystem, including patient safety, workforce safety, facility safety, so safety kind of in a larger frame. Affordability and efficiency are obviously very important. The management of chronic conditions, wellness and prevention, seamless care coordination, which also includes seamless communication, and we've added behavioral health, and I would add mental health and substance use disorders there because we recognize how important that is. This is all built on the foundation of the consumer and the caregiver voice so that we are always taking that into consideration. And obviously, as you are developing measures, ensure that we are always from the very beginning listening to the patient voice, making sure that we have representation from a wide variety of patients and including the consumer in all that we do. The goals of meaningful measures, again, I spoke of them before, utilize only the highest quality measures that impact these domains, align measures across all of our value-based programs across all partners, prioritize outcomes and patient-reported measures, transform to digital, and develop and implement measures that reflect social and economic determinants and that decrease disparities. Next slide, please. This just highlights, again, leveraging quality measures to highlight disparities and close performance gaps. CMS has plans to expand our confidential feedback report stratified by dual eligibility, and we're looking at other means of stratification to provide feedback reports, introducing plans to close equity gaps. And we spoke already of ensuring equity by supporting the development of either social and economic status, SES measures, SDOH measures, and are partnering with the Office of Minority Health, looking at the health equity system score as another potential marker. So with this, I'm going to pass the baton to Jocelyn in just a moment. Once again, thank you to all of you for your work in measure development. We think this area is extremely important. It is the tool that we use to highlight quality, safety, and really outcomes in healthcare to ensure that we are getting the best value for all customers and all beneficiaries. And we look forward to working with each one of you, to hearing your feedback, and hopefully this at least gives you some directionality for what CMS is considering around our quality measurement framework. Jocelyn, thank you, and I will turn it back to you.
All right, thank you, Dr. Schreiber, and thanks to everyone joining today's call. We can go to the next, actually skip 2 slides. We're just going to provide a quick overview of the call for measures. So the annual call for measures process asks stakeholders, including clinicians, professional and medical societies, researchers, consumer groups, to send or recommend quality measures for consideration in the quality performance category for MIPS. Stakeholder recommendations are a part of our rigorous quality measure selection process, since it's likely that stakeholders would submit measures that are meaningful and applicable to them. Next slide. So as Dr. Schreiber had mentioned, the Meaningful Measure Initiative serves as a guide to evaluate each measure for inclusion on the MUC list to ensure that the selection of measures pursues and aligns with the agency's priorities. Through setting program needs and priorities, CMS hopes stakeholders will continue to take this into account when developing measures and submitting these measures for consideration on the MUC list. The CMS quality measurement strategy continues to drive towards patient-centered, value-based care through the development and selection and implementation of measurement that includes accelerating the transition to digital measures, promoting the use of all-payer data, increasing alignment of measures across the agency, and of course, using that patient voice. Next slide. Additionally, we wanted to provide just a high-level timeline, which may seem a little different from this past year, but in a typical year, we likely open the call for measures in January. We use, in March and April timeframe, we hold educational webinars for the call for measures, and this will come to a close in May. We use July and August to review those measure candidates and evaluate how the measure aligns with CMS's needs and priorities, and we'll definitely take a deeper dive into that in the coming slides. By September, we provide feedback to the submitters as the MUC list enters the CMS HHS clearance process. Typically, the MUC list is published no later than December 1st to gear up for the MAP meetings that occur during December and January. The MAP recommendations are published by February, and just to level set, the MAP, or otherwise known as the Measure Applications Partnership, is to provide an opportunity for stakeholders to provide a recommendation on the measure to HHS, with the overall goal is to maintain transparency and encourage public engagement. And actually, we just wrapped up that MAP meeting cycle this past week, and we definitely hope to see you all there next year. Next slide. All right, providing an overview of just the expectations of what goes on within the call for measures. In order to be considered as a MIPS quality measure, a submitter is required to submit a few different items. Obviously, we need the measure information, but along with that, we would need the peer-reviewed journal article template, which we do provide a formal template for you to fill out as a submitter. And then that doesn't mean that the measure actually has to be submitted to a peer review article or journal article. We take care of that on the CMS side. All measures need to be fully developed and tested at the clinician level and feasible at the time of submission. There may be additional outreach following the call for measure close to gain clarity if the team has questions or anything like that as it's being evaluated. We do want to note that the JIRA system was retired after the 2019 call for measures, and CMS is proud to announce that they'll be moving towards a MUC entry review information tool, otherwise known as MERIT, for the 2021 call for measures. And more information will be provided at a later date. Okay, moving on to after the submission. If the candidate measure is placed on the MUC list, the submitter is expected to attend those NQF MAP meetings that I just referenced in the timeline. This allows the stakeholders to ask questions, provide feedback, and really fully understand the measure prior to engaging in the voting process. And finally, once the measure, or if the measure is proposed and finalized within MIPS, the measure steward would maintain the measure through the annual revision process. This process ensures that the measure aligns with the current guidelines, any updates to coding. As we know, there's always annual updates to the ICD-10, CPT, etc. We do promote coordination of the measure changes across collection types, governing bodies, and other CMS programs, as this will contribute to reducing clinician burden, reporting burden. And then lastly, there will be, CMS does host measure steward meetings and would request that those measure stewards attend as scheduled. All right, moving along to measure requirements. We can go to the next slide. actually skip that next one. All right, as I had mentioned, testing. So for a measure to be considered, it must be tested at the clinician level at the time of submission. We're not expecting any type of extension to submit testing data. So once Call for Measures closes, we would need that testing information. This includes reliability testing to ensure that the measure can reproduce results. This can be demonstrated by the signal to noise ratio. We also require that the measure is valid and accurately represents the concept and achieves its intended use. We would direct you to the CMS blueprint for additional guidance on testing and have included the link within the resources section as well as the next slide in this presentation. So we can go on to the next slide. All right, for ECQM, the ECQM team evaluates the testing and readiness by reviewing the measure information to ensure that it uses CQL or clinical quality language as the expression logic in the health quality measure format, and requires that data collection mechanisms must be able to transmit and receive requirements as identified in MIPS regulation. Similarly, ECQMs assess the reliability and validity using signal to noise. The CAPA agreement is one way to evaluate validity, and it only tests the validity of the ECQM data elements, specifically agreement between EHR extract and the chart extracted information. Score level validity is done through hypothesis testing with a gold standard. And then lastly, the feasibility can be demonstrated by the NQF feasibility scorecard. The team also reviews the specification by assessing the map output, the value sets needed to be published on the VSAC, and then the body test cases. And additionally, the ECQM team provided a number of different measure testing resources for you on this slide. Moving along to the next slide, we'll take a peek at the future of ECQMs, and really we just wanted to put this on your radar for the future. So the FAST Healthcare Interoperability Resources, otherwise known as FHIR, is a data interoperability standard developed by HL7 International for the purposes of exchanging healthcare information electronically. FHIR will combine a simple framework of building blocks or data elements with the latest web technology to standardize the way healthcare data is being represented and shared. It is flexible enough to be used across a variety of EHRs and other healthcare exchange platforms. So how would this impact the ECQMs? Instead of using the QDM data elements and QRDA reporting, FHIR data model and FHIR reporting requirements will be used for representing the reporting ECQM data. The FHIR standard has the potential to reduce overall burden on measure developers and implementers by providing faster real-time access to quality data, aligning data exchange standards within the clinical support initiatives, and automating both EHR data retrieval and quality data submission. So exciting things happening in the world of ECQMs, but I do want to mention that their CMS is planning a FHIR 101 webinar taking place on February 3rd. So we can place that registration link in the chat if that would be helpful, but wanted to put that on your radar. Next slide. Okay, so beginning with the 2020 Call for Measures process, submitters were required to link their MIPS or their quality measure candidates to an existing or related cost measure or improvement activities as applicable and feasible. Submitters are required to provide a rationale as to how they correlate to each other, to the other performance categories and activities as part of the Call for Measures process. So this will aid in the development of robust and cohesive MVPs in the future. And when they are available, submitters may also be asked to link to an existing MIPS value pathway. And we'll discuss the transition to MVP later in this presentation, but wanted to note this is one of the requirements. Next slide. All right, perfect, thank you. So each year, CMS assesses the quality measure inventory and identifies specialties or clinical topics that are not widely represented within the MIPS quality measure inventory. And so for that reason, we would request that measures that support identified gaps be submitted. From our initial review, we're seeking measures applicable to the specialty and topics listed on your screen. And as Dr. Schreiber mentioned, we really are seeking to have that patient voice represented in the quality measures, whether it be from patient-reported outcomes or shared decision-making measures. But again, those are just some areas that we're seeing gaps in measurement and clinical topics. Next slide. All right. In addition to clinical topics and specialty preference, we're also seeking to move towards more outcome-based measures and include patient-reported performance measures that utilize PROMs, patient experience measures aimed to improve the customer experience that support innovative approaches to improve quality, accessibility, and affordability. And most importantly, empowering patients and clinicians to make decisions about their healthcare together. This incorporates that patient voice, which is definitely a priority within CMS. Next slide. All right, we're aiming to reduce patient or reporting burden for clinicians in a number of ways. So you may have noticed that we've been adding administrative claims measures, and these measures do not require any additional action on the behalf of the clinician, but are automatically calculated by claims data. Additionally, that digital quality measurement that leverages sources of healthcare information that are captured and can be transmitted electronically via interoperable systems will assist in this effort. In addition, other ways using that transition to FHIR will also assist in reducing burden. And additionally, by aligning the measures across programs, those clinicians who participate in multiple programs will have decreased burden as they will not have to implement the same measure concept in multiple ways based upon the program. And this goes back to that core quality measures collaborative CQMC. Next slide. Now we'll enter into sort of the heart of the presentation. So each year we receive and review measure candidates where we provide consistent feedback, whether it is to revise or to combine. But we wanted to take a minute to walk through a couple of the typical detours to consider when developing a measure so that your measure has a better opportunity to move forward to the MUC list and eventually MIPS implementation. So first off, we have splitting. We do not want to see that measures split into a single measure into several different measures. We would like folks to explore opportunities to combine into a composite for a greater picture of quality. So for example, we would look at a MIPS measure, measure 441. This is IVD optimal care. This takes a more comprehensive approach to managing and caring for patients with IVD by assessing not just one of the components individually, but a broader picture of care. So in this measure, it would be assessing that the blood pressure is controlled, that the patient does not use tobacco, and is taking either an aspirin antiplatelet and statin unless contraindicated. What we don't want to see is those four components come in as four different measures. So yeah, definitely take a peek at that MIPS measure 441 as an example. Next, we don't want to see a duplicative or a one-off measure to an existing MIPS measure. We would really encourage the collaboration with MIPS measure stewards to be inclusive of appropriate clinical settings and a patient population. So an example of this, if a measure didn't contain, for example, the inpatient setting, but you feel it applies, that is, it's a good measure and it should, we don't want to see that measure submitted with that patient population or that inpatient setting as a separate measure, but we'd rather request that you'd reach out to the measure steward to see if they're open to expanding the clinical settings represented within that given measure. Next, as measures are submitted, we do look at the burden that it may pose to a clinician or group, and would encourage development of measures that also take into consideration, especially leveraging those digital tools that were mentioned earlier. And the last do's and the do nots is an important aspect. Definitely, you want to make sure that your measure as it's being developed does not have any unintended consequences. So we have seen measures come in as like a cost resource measure that actually was looking to deprive oncology patients with shortness of breath from their palliative oxygen therapy. So those are the kinds of things that we want to put the patient first and make sure that we're taking that in consideration, or those unintended consequences. Okay, moving on to the next slide of the do's and don'ts. First is submitting a measure that only captures the assessment or that a survey was completed. This is probably the most common scenario that we see, and we will be very consistent in responding that these measures should be combined into a single measure that emphasizes a robust quality action. However, if you do think it's important to measure that assessment separately, there is always that option to create a measure similar to the MIPS measure 226, and this is looking at tobacco use, screening, and cessation. So this measure in particular breaks it into 3 different rates. So the first rate being that assessment only, and then second rate being those that assess positive, who received the quality action of the tobacco cessation, and then the third is just that combined rate. So if this delineation is important, there are opportunities to provide a more granular data to the clinicians if it was structured in this manner. So just keep that in mind, and I definitely would say we would not be looking for those assessment only or completion of survey measures. Next is, as previously mentioned, we're looking for patient-reported outcomes, and definitely believe this is very apparent within all the CMS resources that we're seeking more outcome-based measures rather than the process measures. All right, moving along to the third item is measures should align with the current guidelines. And if they are not in alignment with the current guidelines, they would not be considered for the MUC list. So for measures already in use in MIPS each year during the measure maintenance process, the measures should be updated to align with the current guidelines. And why we do this is if a measure remains misaligned and creates misleading results, it may be suppressed until the measure is updated. While the clinicians don't get scored on these measures, it does place extra burden on the clinician to collect data that ultimately does not contribute to their MIPS final score. So want to make sure that those are in alignment there and meaningful. But we do rely on the measure stewards to alert CMS if any guideline issues. Moving on to the attribution. Attribution is the assessment of results of a measure to a reporting clinician or group. MIPS is a clinician group focused program, and we want to implement measures that are attributable to that clinician group or virtual group. An example, we have seen measures that we would reject because they aren't able to be tied back to a quality action of a clinician. So looking at medication shortage or equipment supply shortage, things like that does not really speak to the care that's being provided by the clinician or group, and those types of measures would not be appropriate for the MIPS program. Okay. Lastly, on this slide, all the components of the measure should be consider the evidence. So denominator exceptions or medical reasons should be precisely defined as an evidence-based. A broadly defined medical reason, such as any reason documented by a clinician, may create uneven comparison if some clinicians apply reasons that may not be evidence-based. However, medication specified in a numerator is shown to harm fetuses and the patient's pregnancy is documented as a reason for not prescribing that indicated medication, this should not negatively affect the clinician's performance, as there was evidence-based support not to prescribe the contraindicated medication. So just taking and making sure all elements are precisely defined and take in consideration publications and evidence. Moving on to the last slide of the do's and don'ts, we ask that you do not submit a measure that is a never event with no variability in the clinician's performance. Well, in this example that we provided, we never want a fire in the operating room. They occur so frequent that it's not a very meaningful measure. So if you're looking at a complication rate measure developers should ensure that they are trying to close a gap on a given complication or event. They are important measures. We don't disagree there, but when we have to consider how the measure will be scored, if there's less than a percentage separating the top performer from the bottom, it is hard to say that one clinician is doing significantly better when it's just separated by 1 percentage point. And lastly, we do not want to see measures assessing the standard of care. This relates back to the scoring consideration. If there's little variability or gap, it's hard to differentiate performance among clinicians. Measures should ensure that there is a performance gap through testing and investigate any opportunity to revise the measure to be more robust or comprehensive. So this goes back to maybe creating a composite or things of that nature. Right, next slide. All right, we made it through the do's and don'ts. So as mentioned in the last slide, we want to see that performance data and performance gap to ensure we're closing or improving care. Measure performance data would be requested to be included within your submission. Measure performance and evidence should identify opportunities for improvement. And keep in mind that CMS does not intend to implement measures in which evidence identifies high levels of performance with little variation or opportunity for improvement. For example, topped out. So each year, I think we receive submissions and the sample data that they pulled, it may be, the average performance rate is already in the upper 90s. This is not a measure that would be long-lived within the MIPS program, as we do have that policy to retire topped out measures after a given life cycle or extremely topped out measures. So keep that in mind when you're looking to develop a measure. Also, when looking at what tools to use within a measure, we want to make sure that at least they are standardized and validated tools, but additionally that they're non-proprietary. At least there's one option within the measure that's non-proprietary at least. And then lastly, the measures should all be intuitive or have high face validity. And this is very important because this information and the performance feedback can be viewed by the patient within Care Compare. So things to consider there. All right, next slide, please. Future state. So, and I'm sure that some of you of the attendees today are already looking ahead to this, but CMS is looking to transition to MIPS value pathways, otherwise known as MVPs. The goal for MVPs is to create a more cohesive participation experience by connecting activities and measures, resulting in a more value-focused program with reduced selection burden. There's been another number of town halls and RFIs related to this topic, and we're definitely taking all that into consideration. But so how that applies to the call for measures is when we receive your measures, we're taking a deeper dive into how it relates to the different cost measures or improvement activities and how they really complement each other. So is that improvement activity contributing to a better performance within the quality category? So this will be an important link moving forward as we transition over to MVPs. But so as you submit, it's important to provide that rationale and take a peek at the cost measures inventory or the IA inventory or improvement activity inventory to see how those areas can be complementary. All right, and lastly, just we did, as I mentioned, we provided some resources. If you can go to the next slide, we'll go over them really quickly. And we'll open it up to question and answer. So the blueprint is a very handy resource when it comes to measure testing and development, a lot of supplemental materials as well. And then we will be posting the fact sheet as well as the peer-reviewed journal templates on the pre-rulemaking website. We also provide a couple of examples that are handy to take a peek at when populating those templates. And lastly, the ECQI resource is listed there for any of the ECQM questions. And again, if you have any questions on the content, you're welcome to reach out to the PIMS Quality Measure mailbox, and we can help you in that aspect. So I will turn it back over to Ketchum, I believe, for any question and answer.
Great, thank you, Jocelyn. All right, yes, now it is time for the question and answer period of today's webinar. To ask a question, you can submit it via the chat box and we can read it out loud. Or if you'd like to ask a question over the phone line, you can toggle the hand icon on your go-to menu and we will go ahead and unmute your line. Okay, so just to get started, we have a few in the chat box. Your first question asks, does CMS recommend any particular software for quality measured data collection and analysis?
So, Dr. Green, I don't know if you want to take this one, but I do not believe that CMS endorses any particular software.
Sorry, I couldn't get off mute. You're absolutely right. We don't endorse any particular software. We do, there is obviously ONC certified software. We also do a qualification of potential registries and QCDRs as third-party intermediaries / vendors. And those are posted on our website, but we don't endorse a specific one or product.
Okay, great. Thank you for that. All right, your next question asks, are patient-reported measures allowed during the public health emergency?
I'm sorry, are patient-reported, say that one more time, please?
Are patient-reported measures allowed during the current public health emergency?
So if by that you mean the CAP survey and things of that nature, yes.
Okay, perfect. Okay, next, is there any resource in regards to the new merit tool for measure submission?
I believe that will be coming out in the near future.
Okay, no worries. Okay, next, how can quality measures with patient-reported outcomes as a basis become digital measures?
Yeah, so I think it's definitely dependent on how the patient-reported outcome or the PROM is implemented. I mean, there could be digital tools upon checking in with your physician or your doctor's office that could be linked into your EHR that could be considered digital.
Okay, great. Okay, next. For MIPS measures, do they have to be specified at the individual clinician level, or can they be specified at only the group or virtual group level?
As a MIPS measure, they should be specified at the clinician level as MIPS CQM.
Okay, great, thank you. Okay, again, to ask a question over the phone line, please just toggle the hand icon on your go-to menu and we will go ahead and unmute your line. Right. In the meantime, is CMS working towards developing quality measures for wound care?
Go ahead.
I was going to say, I'm not aware that we are, but if anybody else knows differently, please speak up. But as mentioned, I'm not aware. We do have, I believe the QCDR, we have some wound measures in QCDRs, I believe. Jocelyn, maybe you can speak to that.
Yep. We have a few in QCDR world, but then also if there is I believe these would be listed in the measure development plan of what's coming down the pike or in the pipeline. So that might be a good resource to check for any specific topics. So you're not duplicating effort.
Okay, great, thank you. Okay, we've had a few questions come in over the phone line. So first, Kathy Johnson, we'll go ahead and unmute your line. And Kathy, you're self-muted, so if you'd like to unmute on your end, you can go ahead and ask a question.
Great, thank you so much. What I was wondering about is, with the APP coming in 2022, and all the submissions are going to be through the APP, it's an ECQM data measurement. It looks like it's only going to be 3 measures at this point. I was trying to wrap my head around, is this a continual submission, so this data is flowing and it's constantly updated? And how will that affect the submission period? Any information or any places I can go to find out more about that?
Not sure that we have the APP folks and submission folks on this particular call.
Okay. Can you help me figure out what resources, where I should go to find out? I feel like I'm reading between the lines that it means that it's going to be continually updating your performance based on that flow of the data going in, but I don't know where to go to confirm that.
Yeah, Dr. Green, I don't know if you know off the top of your head, but I would probably, since this is more call for measures based, I would submit your question to the QPP Service Center, and hopefully they can direct you.
Great, thank you so much.
Okay, great. Okay, next question asks, do you require testing at other levels of analysis as well, such as facility plan or state?
For MIPS, it's at the clinician level.
Okay, great. All right, your next question asks, how can QCDR measures be a part of an MVP?
I know Sophia's on, but I do know that there is additional requirements outlined in the 2021 final rule that require them to be fully tested, actually be approved for the prior year, things like that. So, and it would be part of the notice and comment rulemaking process. But Sophia, do you have anything else to add on that?
No, you've covered it. QCDR measures, as you've mentioned, Jocelyn, need to be fully tested before they're considered for inclusion within the MVP. All MVPs need to go through notice and comment rulemaking. So you would need to have that approval through the self-nomination process that your measure is approved before we put it in the rule. We don't want to be in a place where we're temporary or tentatively including measures that have not gone through the full approval process, the QCDR measure approval process. So I just want to caveat that the full testing and approval, and then the measures included within the MVP as a part of the notice and comment rulemaking process.
Okay, great, thank you. Okay, your next question is from Maggie Lone. So Maggie, we'll go ahead and unmute your line. All right, and Maggie, if you'd like to go ahead, you may ask your question.
Thank you very much. So not to belabor the point about the clinician level reporting, but my question regards specialties such as pathology that primarily solely report as a group. So does that clinician level reporting include clinician group level reporting for that kind of specialty?
Yeah, so I know for MIPS reporting, we do have to, I mean, a pathologist can choose to either report as a clinician or a group, but for the purposes of MIPS requirements, it should be tested at the clinician level. But we know that, you know, pathology, from the research that we've done, they are participating more as a group. So to answer your question, it is testing at the clinician level.
Okay, and is there accommodation or recognition that the results would be low at that level, given that they do their work as a group? Does that make sense?
I'm not quite following, like,
Right, right. So, you know, pathology groups,
Yep.
you know, pathologists work as a team, as a group. So it's rare that a single pathologist could claim credit for performance.
Oh, yeah. Yep.
Yeah. So the testing would demonstrate that as a group, they would, especially for a pathologist-centric measure, that they would be able to report good quality as a group. But if you were to parse it out as trying to do that for a single pathologist, the test results would be low, just by the nature of their work.
Yep, we may have to, if you want to email us, I think we can chat through this a little bit further in detail, but I think I know where you're going. But definitely let's touch base and just email the quality measure support, and we'll make sure that you have what you need.
Great, thank you.
Yep.
Okay. All right, your next question asks, when will the new merit system be up and running?
I know, I believe Helen is on, but last I heard it would be in the next couple days. Yep. Hi, Helen.
Yeah. Hi, how are you? Thanks for the question. Yeah, so our anticipation is that it will be live starting tomorrow, but it'll be live throughout the whole submission period. So feel free to go in and take a look. We're really excited about it.
Great. All right, thank you for that. Okay, next question asks, when do you anticipate the 2021 MUC submission guidance will be posted to the pre-rulemaking website?
As far as the MIPS call for measures, quality measures, we are hoping within the week.
Great, thank you. Okay, next you have a question on the phone line from Ronan Rosenblum. So Ronan, will go ahead and unmute your line now, and you may go ahead and ask your question.
Hi, so first, thank you for the update, very interesting presentation. So I would appreciate if you can provide us with specific information about the MUC list submission dates for 2021, as far and as well as if there is a time frame to submit after the MUC list submission updated data analysis. I just checked the site and it's not updated. And you mentioned in the beginning of the talk something around May, but if you can be more specific about the timetable for this year, I will appreciate that.
Yep. So May 27th is the, yep, go ahead.
No, I was just going to say, yeah, May 27th, this is Helen, sorry. And so again, it will be open through then for submission of your measures. And as far as we are concerned, I know this past season we allowed for test information and data to be submitted thereafter. We are looking to not do that. We did that as a result of the pandemic that we were all dealing with. And so for this particular cycle, we are looking to have all the information in by that date. Thank you.
Okay, thank you.
Okay, great. All right, next question asks, what is the best way to identify measures that are in a planning or pre-development phase, i.e. they are not listed yet in the CMIT?
The best resource at this point I know of you know, I do know that there's a QCDR measures list that has a number of measures. I think there's over 400 this year. That would be a good resource to make sure you're not duplicating efforts, the measure development plan. And again, as I had mentioned, we do have those priorities listed for those clinical topics and specialty areas. Would be a good resource.
Okay, great. Okay, next question asks, is there a resource that explains and gives an example and format for a face validity document that is acceptable to CMS?
I think the best resource at that would be the blueprint, but there's no you know, set you know, reliability threshold or whatnot. But yeah, definitely the best resource for any of the testing information would be the CMS blueprint.
Okay, great, thank you. Okay, next question asks that some outcome measures require a preliminary process step to collect data on the outcome, such as consistent prom completion to assess PRO-PM. So will CMS take this into consideration when reviewing these process measures? If the process is rejected, but the outcome is approved, the outcome will not be viable.
I think I understand this question. Dr. Green, feel free to chime in, but it sounds like you want an assessment measure separate from the outcome measure, is what I'm assuming, but feel free to raise your hand if I'm not interpreting your question correctly. So I think at that point, I mean, there is opportunity, as I mentioned, you know, to combine those, look at the outcome or look at the assessment, provide a performance rate, but then what we would score or what we would look at is we want to see how the outcome would be measured. And I think it could be one measure depending on how they would construct the measure.
Okay, great. All right, as a reminder, to ask a question over the phone line, you may do so by toggling the hand icon on your go-to menu, and we will go ahead and unmute your line. In the meantime, regardless of the submission date, will there be an opportunity to submit additional data at a later date? And if so, what would that date be?
Helen mentioned.
Hi, again. Oh, sorry. I always get to the mute button fast enough, so I apologize. Yeah, so just as she was about to say, that we are looking for all the information, all the data to be submitted by the end of May. We are not looking to have an extended period for additional information. So again, if you could just please have all your information ready to go by then, that would be great. Thank you. Okay, great. Thank you. All right, next question. Will CMS provide clarification on the distinction between digital measures and ECQMs, or will CMS create materials to help delineate digital measures from other types of measures?
I think ECQMs could be considered a subset of digital measures. So a digital measure can use a number of different interoperability methods to sort of tie into the quality measurement. But I do think that CMS, and correct me, they're will be providing additional guidance on what would be considered a digital measure.
Yeah, I can't say that we have something definitively on the drawing board, but I can't on the other hand, I can't imagine that we won't be providing more context, more examples, etc. Sophia, I don't know if you're able to comment on this or not.
Yes, I think Sophia had to hop off actually.
Okay. Thanks,
So
sorry.
this is Lisa Marie. We are in the process of looking at and defining and finding ways to be able to clearly delineate what we mean by digital measures. So we are in the process of doing that.
Thank you, Lisa Marie.
Great. All right. Thank you. Next question asks, will there be any requirements around digital measures and MVPs now or in the future?
I do believe that MVPs promote the use of digital measures. We are still in the midst of policy writing for that particular area, but that is one of the areas that they would like to see more digital measure used.
All right, great. Okay, next question asks, do you have preferred psychometric techniques for reliability testing of performance scores?
No, I don't think there's any preferred method, just what is outlined in the blueprint.
Okay, great. Just had a few more questions to clarify the date of MUC list submission this year in May. Was that May 27th?
Yep.
Okay, perfect.
And
All right.
will say, just really quick, I want to clarify one thing. That's MUC list submission. That's when the candidate submission closes for call for measures, and then that is when we look and review all the measures to see if it will include that particular measure on the MUC list. So I just wanted to clarify those two different processes that go on.
Great, thank you. All right, we do have a few more minutes left for questions today. So if you'd like to ask a question, you may do so by submitting it through the chat box and we'll read it out loud. Or of course, you can toggle the hand icon on your GoTo menu and we can unmute your line to ask a question over the phone line. So two options there. Feel free to keep submitting your your questions. All right, next question is a bit of a comment, if you could clarify, but they note that the current MAT functionality limits the ability to develop composite measures.
Can you repeat that question? Is it a question?
It is a statement. I'm wondering if you have any response to it, but it just says current MAT functionality limits the ability to develop composite measures.
I don't know if you're looking for a statement. This is Joel. We've noticed the issue in our own measure development efforts. I don't unfortunately have an immediate solution to offer you at this point, but it is something that we're very much aware of.
Okay, great, thank you. All right, well, that's actually all the questions that we have at the moment. So again, if you'd like to ask any questions, you may do so by submitting it over the chat box, or you can raise your hand and we can take a few more questions over the phone line. So we'll give it just 1 or 2 more minutes. And then, Jocelyn, we can pass it back over to you. All right, just a general call. We do have a few more minutes left, so we'll see if there are any questions left.
Well, I think I'm going to actually jump in if that's okay, Lauren. If another question comes in while I'm speaking, we'll certainly be happy to take it. I just want to thank everyone all of our participants for dialing in, for your thoughtful questions. And we really appreciate your interest and, working with us to try to make the measures in the MIPS program as good as they can be and as useful and meaningful to patients and clinicians alike. I'd also like to take a second to thank all of our contractors who helped work on this, Ketchum folks, the PIMS folks, and I know there are others, and I'm sorry if I'm leaving you out, but also want to recognize Lisa Marie Gomez, who was instrumental in helping to put this together. She's a CMS person that we work closely with on our quality team. And thanks to all the SMEs, Sophia, Joel, and Dr. Schreiber for giving an opening remarks, as well as anybody else I left out. So if I did, I didn't mean to. But thanks again, and I'll turn it back to Lauren one more time to see if any questions came in. If not, I wish you all a safe and pleasant rest of your day.
Great. All right, no more questions are on the line. So that concludes today's webinar. Everyone may now disconnect.
Thanks, everybody.